Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is part 3 of Congenital Cardiac Anomalies, where we look at blue pediatrics, cyanotic anomalies. As we've mentioned previously, the first congenital heart defect was described by Leonardo da Vinci in 1531 when he identified an atrial septal defect. Now the learning objectives for this session are to review shunt terminology again, look at cyanotic cardiac anomalies, by no means extensive. If you want further anomalies discussed here, let me know. We'll look at the medical interventions and some of the surgical interventions. So let's review. The term shunt refers to an abnormal connection allowing blood to flow directly from one side of the heart circulation to the other, right to left, left to right. A cardiac shunt then is a pattern of blood flow in the heart that deviates from the normal circuit. It can be described as right to left, left to right, bidirectional, systemic to pulmonary, pulmonary to systemic. Now, a right to left shunt occurs when there's an opening or a passageway or a channel between the atria, the ventricles or the great vessels, the aorta and the pulmonary artery. The right heart pressure is higher than the left heart pressure, and this results in a shunt. And it could be due to a one-way valve opening. A right to left shunt allows deoxygenated systemic venous blood to bypass the lungs and return to the body's systemic circulation without oxygenation. And this results in a blue baby or a blue pediatric. The most common right to left shunt with congenital heart defects is Tetralogy of Fallot, and this accounts for about 5 to 6% of congenital heart anomalies. And if we looked at a chest x-ray, we would see that you would typically see what was referred to as a boot-shaped heart because of the 4 anomalies. Now, in Tetralogy of Fallot, as I said, there are 4 tetra defects, and they include a ventricular septal defect, VSD, which we've discussed previously, pulmonary valve stenosis, an overriding aorta, which is misplaced primarily because of the VSD, it sits in the wrong place, and a thickened right ventricular wall as a result of right ventricular hypertrophy, where the right ventricle has tried to pump blood past the stenotic aortic valve. This has resulted in hypertrophy. And as we mentioned previously, this can result in a boot-shaped type heart. Associated syndromes, well, TOF, Tetralogy of Fallot, doesn't really have any identified genetic cause. However, pediatrics with Tetralogy of Fallot are more likely to have a chromosomal disorder, something like Down syndrome in particular, or Alagille syndrome or DeGeorge syndrome. What's the medical management? Well, the medical management is fairly consistent. Vasopressors and antibiotics in particular. Treatment for patients with Tetralogy of Fallot depends on, however, the type and the size of the defect and its effect on the heart. And there can be complications such as congestive heart failure, which is associated with pulmonary hypertension, and endocarditis, which requires antibiotic prophylaxis. What's important with the medical management is that it's probably important to maintain the ductus arteriosus, and this can be done with prostaglandins. And prostaglandins are utilised to maintain the patency of the ductus until surgical ligation can be performed, or when surgical ligation of the PAD is not immediately available or indicated. To maintain the ductus, low-dose oxygen is recommended. In healthy newborns, we've mentioned previously, the arteriosus usually closes 12 to 24 hours after birth. And this occurs because of contraction of the muscles in the ductus, which are sensitive to oxygen. acetylcholine, bradykinin and ethylene, but we're focusing on oxygen. And decreasing oxygen, which is called permissive hypoxia, promotes dilation of the ductus arteriosus, which you want to remain patent until other interventions can take place. In the medical management, sometimes these babies, infants, children, pediatrics, have what are called TET hypoxic spells. And this is an episode in which the pediatric becomes severely cyanosed, very agitated and short of breath. And this is caused by a sudden decrease in blood flow to the lungs, increasing the right to left shunt via a VSD or an ASD or both. TET spells can be precipitated by dehydration, agitation or fever, or they can be idiopathic, unknown why. And treatment includes calming the pediatric, administering oxygen or fluids. However, the knee-chest position may assist with terminating the spell because this decreases the right to left shunt. Palliative surgical management can include the following. The Blalock-Taussig shunt, which has since been modified since its creation. The modified Blalock-Taussig shunt increases pulmonary artery blood flow. So, this is a palliative surgical technique that attaches a shunt to the subclavian artery to the pulmonary artery. And it's the high pressure of the arterial system that forces blood through the BT shunt to the lungs to increase oxygen uptake and normal oxygenation. Blood flow from the left or right subclavian artery, depending on where it's positioned, to a pulmonary artery, right or left, increases blood flow to the lungs. The definitive surgical treatment, however, most ideal between 2 and 4 years of age before significant changes occur within the heart and the circulatory system. And it typically involves a ventricular septal defect repair and the use of a transannular patch. Now the goal is to repair the 4 defects of Tetralogy of Fallot so the heart can function normally, and surgery involves widening or replacing the pulmonary valve and enlarging the right ventricular outflow tract to the pulmonary artery. This is the pulmonary artery and the pulmonary valve, and this is to improve blood flow to the lungs. Complex surgery, but very, very effective. Finishing with a transannular pericardial patch or some artificial material, maybe Gore-Tex. Dextro-Transposition of the great arteries, or D-TGA, is a birth defect of the heart in which the main pulmonary artery and the aorta are switched in position or transposed. Now this is potentially fatal as a congenital heart defect because the pulmonary artery and the aorta are switched. They have different roles. And the switch means that now the aorta, which normally carries oxygenated blood to the systemic circulation, is now carrying deoxygenated blood. And the pulmonary artery, which normally carries deoxygenated blood, is carrying oxygenated blood to the lungs. Now there are a number of DTG or Dextro-Transposition of great artery variations. However, unless there is a shunt present within the heart, it's incompatible with life. So if there's no shunt, note, pulmonary artery is carrying oxygenated blood and the blood flow circuit is closed, which means the pulmonary arteries are carrying blood to the lungs, away from the lungs, back to the lungs, away from the lungs, a closed circuit. The aorta is carrying deoxygenated blood, which goes to all the systemic organs, comes back to the systemic organs, comes back. So meanwhile, the systemic organs are getting more acidemic as a consequence and more hypoxemic. So this is with no shunt. However, the image that you're seeing in front of you, you've got for the aorta, the pulmonary artery, a VSD, and a patent ductus arteriosus. So there are two shunts present in that situation, which means it's still compatible with life. Another variation could be just a VSD, ventricular septal defect, which means that there's a shunt. So you get mixture of oxygenated and deoxygenated blood. Sure, the infant, the child, the newborn will be hypoxic, but at least they can still survive. With no shunt, they won't survive. Then you've got the aorta and the pulmonary artery with a patent foramen ovale, which essentially is an atrial septal defect. In this variation, you've got a right aortic arch. Then you've got another variation where you've got the aorta, pulmonary artery, right aortic arch, and a ventricular septal defect. So there's still some admixture of oxygenated and deoxygenated blood. Still compatible with life. When you get D-TGA, on chest x-ray, the heart looks sort of elongated. They call it an egg on a string image, which is very unique. It's very easily identified. Have a look at my Dr. Manny Learn shops, which deal with chest x-rays and changes with cardiac images, available on YouTube as well, if you're interested in radiology. Doesn't make you a radiologist, doesn't make you a radiographer, but it gives you an insight into certain conditions on chest x-ray that deal with the heart. Now, transposition of the great arteries is one of the more common, however severe, congenital heart defects. And typically, it's rarely associated with genetic syndromes such as Turner's, Noonan, Williams, or Marfan syndrome. And in Down syndrome, it's virtually absent. Another variation of transposition of the great arteries is called L-TGA, Levo-Transposition of the great arteries, also known as congenitally corrected transposition of the great arteries. And this occurs when the connections between the atria and the ventricles and the ventricles and the arteries are abnormal. The right ventricle is where the left ventricle should be, and the left ventricle is where the right ventricle should be. So in this situation, the right ventricle gets really overworked because it wasn't designed to do the work of systemic pumping. And the left ventricle subsequently gets underworked and weaker because it wasn't meant to be pumping blood just through the pulmonary circulation. The right ventricle will eventually fail and the left ventricle will become physically challenged, especially if corrective interventions are taken. What's the medical management for transposition of the great arteries? Well, similar to others, it depends, however, on the type, the size of the defect and its effect on the heart. And complications can be congestive heart failure with pulmonary hypertension, and endocarditis can occur as well, which requires prophylaxis. So vasopressors and antibiotics are typically indicated. A part of the medical management includes maintaining a patent ductus arteriosus, and this requires prostaglandins. And the prostaglandins are utilised to maintain the patency of the ductus until other interventions are available or indicated as safe, because the infant may be unstable. Also, utilising low-dose oxygen again, because as we mentioned previously, in healthy newborns, ductus arteriosus closes about 24 to 48 hours after birth, and this occurs because of contraction of the muscles of the ductus, which is sensitive to oxygen. And decreasing the oxygen, permissive hypoxia, promotes dilation of the patent ductus until other interventions are available. Non-surgical management includes balloon atrial septostomy. And this is the Rastelli procedure, which is also known as balloon atrial septostomy. And as we've indicated previously, this is a procedure where a balloon tip catheter is advanced in the left atrium from the right atrium through a patent foramen ovale, and the balloon is inflated and abruptly withdrawn back into the right atrium, therefore enlarging and opening the atrial septum, creating an ASD essentially, an atrial septal defect, or a patent foramen ovale. And this allows admixture of venous and arterial blood, an important shunt. Now, the definitive surgical management, ideally less than 1 year of age, in an uncomplicated dextro-transposition of the great arteries, an atrial switch can be used, which is also called the physiological switch, and it was first done in 1959 by Senning, who was a cardiac surgeon. You also had the arterial switch, which is also known as the anatomical switch or the Jatin procedure, which was done in 1970. However, it depends on other anomalies, because there are other procedures that can be done as well, which could be the ventricular switch, which was performed by Rastelli in 1964. But it depends on the other associated anomalies. In the atrial switch, the physiological switch, first performed in 1959, this is where a baffle or a conduit is created within the atria that reroutes the deoxygenated blood coming from the vena cava, superior and inferior, to the mitral valve, and then subsequently to the lungs. The atrial tissue is actually used to create the baffle, so it's quite invasive surgery, and can often result in heart blocks because of damage to the SA node, sinoatrial node, and sometimes even the AV node, the atrioventricular node. This is complex reconstruction using right atrial tissue and the interatrial septum, which lets oxygenated pulmonary venous blood flow to the tricuspid valve and to the systemic circulation. However, the Senning technique was difficult to reproduce and was not widely embraced by the surgical community. There's the image, how it's rediverted from the right side to the left side, from the right side, superior and inferior vena cava, to the mitral valve, and vice versa, from the pulmonary veins rediverted to the tricuspid valve. Fairly complex surgery. Then you've got the arterial switch, which is referred to as the anatomical switch or the Jatin procedure. And this is where the aorta and the pulmonary arteries are transected. The coronary arteries are resected with a small patch of aorta and are reimplanted into the new aorta, formerly the main pulmonary artery. So the pulmonary artery becomes the new aorta. The transected great vessels are switched, creating a new aorta, neo, and a new pulmonary artery, new pulmonary artery. The proximal transected pulmonary artery is shifted posterior and anastomosed to the distal aorta. This is anastomosed to the branch of the pulmonary arteries, forming a new neo-pulmonary trunk. The septostomy lesion, the PDA, is repaired. Here's a good demonstration of what actually happens. Prior to 1970, this procedure was usually fatal. It wasn't until Jatin improved it that it occurred. Senning tried it, but they kept failing. And the primary problem was with reimplantation of the coronary arteries, they'd have a heart attack because the coronary arteries would become obstructed or they would become inflamed, inflammation. Jatin improved the procedure, and since 1970 there have been very few fatalities. Another congenital heart defect is called Truncus arteriosus, or sometimes referred to as common trunk. And this is a rare type of congenital heart defect. Instead of having two great vessels, the pulmonary artery and aorta, there's only one, a single great vessel, the Truncus arteriosus, and it comes out of the right and left ventricle as one tube, one trunk with a single outlet valve. And if you remembered in part 1, when you looked at the embryology, the truncus is supposed to separate into the pulmonary artery and the aorta, which obviously it didn't do embryologically. This will result in a big heart and a big trunk. Now, common trunk variations, I'm just using the Collett and Edwards classifications. There are others though. So in type 1, the pulmonary artery originates from the truncus and divides into the left and right pulmonary artery. In type 2, the truncus originates from the posterior truncus. In type 3, the left and right pulmonary artery originate separately from the truncus and there's no pulmonary trunk. And in type 4, there's no pulmonary artery and the bronchial arteries, none. And they join the aorta to the lungs. So if we look at it individually, type 1, the pulmonary artery originates from the truncus and divides into the left and right pulmonary artery. In type 2, the pulmonary artery trunk originates from the posterior truncus. In type 3, the left pulmonary artery and the right pulmonary artery originate separately from the truncus, but there's no pulmonary trunk. In type 4, there's no pulmonary artery or bronchial arteries, and they join the aorta to the lungs. What are some of the associated syndromes? Well, the exact cause of Truncus arteriosus is still unknown, idiopathic. It's been suggested there are some cases that may develop due to interaction of many genetic and environmental factors such as smoking during pregnancy, maybe alcohol intake as well. In pediatrics with Catch-22 syndrome and DeGeorge syndrome or velo-cardiofacial syndrome, they have an increased risk of having associated with Truncus arteriosus. These conditions are caused by an extra or defective chromosome. The malformation, however, is the result of an error, as I indicated, during embryonic development. What's the medical management? Similar, depending on the type, the size, the defect, and the effect it actually has on the heart, because again it can result in congestive heart failure with pulmonary hypertension and endocarditis. So prophylaxis is required. Vasopressors for cardiac support, antibiotics for endocarditis prophylaxis. Medical management again includes prostaglandins, especially to maintain the ductus. Low dose oxygen to avoid is probably better or recommended, depends, because supplemental oxygen may worsen the pulmonary overcirculation. So by decreasing oxygen, permissive hypoxia, it promotes dilation of the patent ductus arteriosus and allows the continuation of the right to left shunt. Palliative surgical management for Truncus arteriosus includes pulmonary artery banding. And pulmonary artery banding is essentially a palliative surgical technique for the correction of congenital cardiac defects characterized by overcirculation caused by left to right shunting of the blood. Now, pulmonary artery banding is reserved for palliation of Truncus arteriosus, which is acyanotic. And the purpose is to reduce pulmonary artery blood flow, because too much overcirculation of the pulmonary circulation will result in remodeling of the pulmonary circuit and will promote eventually pulmonary hypertension and, in the worst situation, Eisenmenger syndrome. Another palliative surgical management technique is the Modified Blalock-Taussig shunt, which we've discussed previously. And the Blalock-Taussig shunt for Truncus arteriosus is for cyanotic situations. And it's a palliative surgical technique that attaches the shunt again to the pulmonary artery and the subclavian artery. And it's the high pressure of the arterial system that forces blood through the BT shunt to the lungs to increase oxygen uptake and normal oxygenation. It's to increase pulmonary blood flow, the modified BT shunt, which we've discussed previously. For cyanotic associations with Truncus arteriosus. The definitive surgical management for Truncus arteriosus is the Rastelli procedure, and this involves the creation of a right ventricular to pulmonary artery shunt and closure of the ventricular septal defect. Now, it's the Rastelli procedure that involves creating a baffle to close the VSD. The baffle also directs blood flow from the left ventricle to the aorta. A right ventricular to pulmonary artery shunt, or conduit, is connected to the right and the left pulmonary artery, and this creates a new neo-pulmonary artery for blood to flow to the lungs. As you can see, there's the right ventricular to pulmonary artery conduit, and it's connected to the right and left pulmonary artery, creating a new pulmonary artery. The VSD is patched, so therefore the VSD is closed, and this creates now two closed systems, pulmonary artery and systemic. This is the Rastelli procedure. Hypo-plastic left heart syndrome is another complex congenital heart defect, and in this condition there's single ventricle physiology. So this is a heart defect with underdeveloped structures in the left side of the heart, and it involves the left ventricle, aorta, mitral valve and aortic valves. You also have another variation, which is right heart syndrome, which is hypoplastic, but we're not going to be discussing that. Now, in this condition, it affects males more than females, and the prevalence is about 1 in every 100,000 live births and counts for about 7 to 9% of all congenital heart defects, and it's fatal. Without surgical intervention, it's fatal and responsible for approximately 25 to 40% of all neonatal cardiac deaths. On chest X-ray, you'll see a big heart, cardiomegaly. Now, the exact cause of hypoplastic left heart syndrome isn't actually known. However, it has been suggested there could be a genetic cause. Pediatrics with mutations in specific genes may have a higher risk of hypoplastic left heart syndrome, and these genes are known as GJA1 or NKX2-5. Pregnant women are always encouraged to avoid alcohol or smoking cigarettes, and controlling medical conditions such as diabetes mellitus, which could have an impact on this condition. Now, the medical management, similar, vasopressors, antibiotics, and the introduction of anticoagulants, because there's an incidence where you could have thrombosis in the native aorta. Complications still are similar to others: congestive heart failure, pulmonary hypertension, endocarditis, so prophylaxis is required. When it comes to the medical management, maintain the ductus with prostaglandins until other interventions can occur. Maintaining the ductus is important, so low dose oxygen, if possible, permissive hypoxemia or hypoxia is encouraged. Non-surgical management includes pulmonary artery banding to reduce pulmonary overcirculation caused by left to right shunting of blood, a balloon cestostomy which allows mixing of the deoxygenated and oxygenated blood by either left to right shunting or right to left shunting through the created ASD, atrial septal defect, patent foramen ovale, septostomy, and a ductus arteriosus stent to maintain patency of the persistent ductus arteriosus, which could close. And this will promote right to left shunt. 1. Bilateral PA banding. 2. Balloon atrial septostomy. And 3. Maintaining the ductus arteriosus with a stent. Other palliative surgical management includes the Modified Blalock-Taussig shunt, which we've discussed previously. However, the Modified Blalock-Taussig shunt for hypo-plastic left heart syndrome is primarily used if cyanosis is an issue. And it probably will be due to the complexity of the syndrome and associated abnormalities. The primary purpose to increase pulmonary artery blood flow. Then you have the definitive surgical management, which is the Norwood procedure. And this is a stage of 3 procedures. The first stage begins at approximately 2 weeks if the newborn or the infant is stable hemodynamically. Now, it involves a Blalock-Taussig shunt, which connects the right subclavian artery to the right pulmonary artery. Then you've got the Blalock-Hanlon procedure, which generates a common atria by septectomy, not cystostomy, septectomy. And this is where the septum is incised to create a common right and left atria. You also had the Damas-K-Stanzel procedure, which creates a new aorta with the pulmonary artery and the native aorta, which is atresic. Stage 2 of the Norwood procedure is the Glenn shunt. And this typically occurs between 4 to 6 months of age if the infant is hemodynamically stable. Now, the bidirectional Glenn shunt connects the superior vena cava to the right pulmonary artery, and in doing so directs blood from the upper body veins directly to the lungs. It bypasses the right ventricle altogether, therefore reducing the workload. And this is performed for hypoplastic left heart syndrome prior to the Fontan procedure. Stage 3 of the Norwood procedure is called the Fontan operation, which creates the Fontan circulation. And this typically occurs between 18 months of age to 4 years of age. But it depends on whether the child, infant, toddler is hemodynamically stable and able to go through this operation. Now, the Fontan operation is the definitive surgical palliation for hypoplastic left heart syndrome, where the creation of a septum for a biventricular system isn't possible. There aren't 2 ventricles here. There's only the right ventricle. The left ventricle doesn't exist, or it's so inadequate it can't be utilised. Now, the Fontan circulation allows systemic venous blood to pass directly to the pulmonary circulation without the need of the heart's ventricular pump. And flow through the lungs is passive and depends purely on systemic venous pressure, diastolic ventricular filling, and the thoracic pump, breathing, to move blood in and out of the lungs. I mean, the Fontan procedure is by no means the same as your physiological circulation, but it's all this infant child has to maintain life. Has a lot of complications associated, which we're not going to be discussing. Now, the Fontan procedure, there are essentially 3 types. you can have the atrial pulmonary fontan, which is where the right atrial appendage was anastomosed to the main pulmonary artery. You can have the lateral tunnel fontan, which uses a baffle within the right atrium to direct blood from the inferior vena cava to the right pulmonary artery. Or you can have the extracardiac fontan, which is generally preferred, and this uses a synthetic Gore-Tex tubing to connect the disconnected inferior vena cava to the right pulmonary artery. It's generally preferred because there's no incision related to the right atrium. There's no suture lines in the right atrium, which avoids cardiac dysrhythmias like supraventricular tachycardias post the surgery, which is a complication of the fontan procedure. Avoided in the extracardiac fontan. Now let's review. Can you identify the following cardiac anomaly? Have a good look. This is Tetralogy of Fallot. What about this one? This is Dextro-Transposition of the great arteries, D-TGA. How about this one? This is Truncus arteriosus, and I haven't gone into the specific types. You can review that. This is Truncus arteriosus. What about this one? Yes, this is hypo-plastic left heart syndrome. What about this one? This is Levo-Transposition of the great arteries, or congenitally corrected TGA. What about this surgical intervention? Yes, this is a fontan procedure. This is the extracardiac. What about this surgical intervention? This is the arterial switch, also known as the Jatin procedure. How about this non-surgical intervention? This is the Rastelli procedure, the balloon atrial septostomy. What about this one? This is the Glenn shunt, or the bidirectional Glenn shunt. For those of you that are looking more closely at it, I didn't really want anything specific. This is hypoplastic left heart syndrome, but this is the Damascus Stanzel procedure as well, with the creation of a new aorta and pulmonary artery. But really I was just looking for the Glenn shunt. What about this surgical intervention? This is the Modified Blalock-Taussig shunt, also referred to as the MBT shunt. Alright, that concludes part 3 of congenital cardiac anomalies. Thanks very much. As I've indicated previously, if you think this is of any value, indicate it to your colleagues and anyone you might think might be interested. Check out some of the other Learn shops and see you next time. Ciao.